I'll be describing a technique which uses a little bit of what has been described so far. The broad ILM peel described by Dr. Paritosh, the inverted ILM flap described by Dr. Srinivas, and the stuffing described by Dr. Mahesh, all combined together along with autologous gluconated blood clumps to form a macular plug. And this procedure is done without gas tamponade. It is the added advantage that there is no gas tamponade for these patients. So why do we need gas to tamponade the macular hole? The use of gas, the way it works depends upon the volume of gas that is there in the vitreous cavity. There are studies which show that hole closure without postoperative prone positioning when there is a gas in the eye, and they have chosen patients who were aphakic, who were pseudophakic, all those patients underwent a phaco-vitrectomy. What I have seen in my practice is that we deal with a very aging population who have arthritis, other comorbid conditions, and my patients are never ever totally compliant to prone positioning. I have not seen a patient in about 20 years of practice as a VR surgeon, a patient who is compliant to prone positioning for the duration of time that we advise. Autologous gluconated blood clumps have been used since time immemorial, I should say. It has been used to delineate the posterior hyaloid phase. It has been used for internal limiting membrane peeling. And what it does is that it makes the internal limiting membrane very sticky. So it sticks to the base of the hole when you do a stuffing with a peeled ILM, and it does not dislodge at all. It stays in place. So this is the modification of the technique. We have used a broad ILM peel and inverted ILM flat repositioning and used an autologous gluconated blood clump to form a macular plug. This is a short animation. This is the first layer of the plug, which is the autologous gluconated blood clump. The second layer is the inverted ILM flap. The third layer is again blood. In this patient, the ILM harvesting was done. A broad ILM peel is done. The flap is too large to stuff into the hole. And when I tried trimming the flap, actually the entire flap dislodges, forming a free graft. The first layer of the plug is placed into the well of the hole, and the free graft is gently nudged into the hole, stuffed into it, and layered over with autologous gluconated blood. This is the third layer of the plug. This is another example where I've used autologous gluconated blood to delineate the posterior hyaloid phase, induced a posterior vitreous detachment, and used the same blood again to do an ILM peel. Like how we use TA, when you use the autologous gluconated blood clumps, it has small clots in it, which layers over the surface of the internal limiting membrane and makes it very sticky, very easy to handle. And you can, here the ILM peeling is done with the autologous gluconated blood staining. The technique is same as before. There is no fluid air exchange. At the end of the procedure, the fundus periphery is examined and closed. The duration of surgery is also shorter. The preparation of the autologous gluconated blood clump is done by the anesthetist at the beginning of the surgery, using all sterile precautions. The blood is drawn from the antecubital vein, and with 2 cc of blood, about 2 to 3 cc of 5% dextrose is added. When we analyzed our findings, we found that there was apposition of the inner retinal layer on day 1. The foveal defect persisted for varying periods of time from 7 to 30 days, and restoration of the outer retinal integrity was achieved in all our patients by the 30th postoperative day. Some patients had redundant floating ILM which persisted for 3 to 4 years without affecting the visual acuity, and inner retinal waves are also observed in some patients. Thank you very much for your patient hearing.
Thank you, Dr. Meena. I request Dr. Rupak